as a board member, Philippine Society for Microbiology and Infectious Diseases, is a medical specialist 3 and training officer at the Research Institute for Tropical Medicine, Department of Health, and is a clinical associate professor, Section of Infectious Diseases, Department of Medicine, UPPGH. Our next speaker is an active consultant, internal medicine and infectious diseases, University of the East, active consultant, internal medicine and infectious diseases, Providence Hospital Incorporated, is a consultant, Section of Infectious Diseases and Tropical Medicine, Department of Internal Medicine, St. Luke's Medical Center, Quezon City, and is a chair, Infection Control Committee, Hospital ng Makati. So let me call to the stage our first speaker, Dr. Arthur Dessi E. Romani.
Magandang hapon po sa ating lahat. I think this is the last session. I won't take up much of your time. I'm just going to give you some updates on leptospirosis, but just as a heads up, wala naman pong masyadong bago except that it's still a problem that occurs here, particularly here in Metro Manila. And these are my disclosures and some of my acknowledgement. Actually, isa lang. Okay, I'd like to acknowledge Dr. Maris Nepomuceno, who is one of our IDS fellows in BGH for most of my slides. So this is the most recent data from the Department of Health. For this year, the first half from January up to June 30 of 2018, we've seen a 76% increase in the number of cases of leptospirosis, and we were past the epidemic threshold, di ba? After June 30, for example, the Department of Health declared a leptospirosis outbreak in certain parts of Metro Manila, particularly in these areas of Malabon, Mandaluyong, Navotas, Parañaque, and even Quezon City. And in the other regions, they have also seen an increase in the number of cases. Okay, in Region 4, for example, 212% increase in number of cases. Sa Region 4B, 333% increase in the number of cases. And in terms of deaths, the overall case fatality of your leptospirosis is 9.68%. If you compare that to our experience back in 2009, noong Ondoy, ang ating case fatality rate, remember noong Ondoy, that was the first time that we were devastated by all these floodings. That was the first time that flood waters ever entered our house. We as fellows, hindi naman kami nag-duty, pero we went on duty just to attend to our leptospirosis patients. The case fatality rate was at 11.3%. So the monthly case fatality rate as reported by the Department of Health, naglalaro po between 9% and 11% for the past year. Okay, that means of 10 patients who develop leptospirosis, one of them will actually die, right? Kasi ang case fatality roughly nasa mga 10%. Okay? And this is something newer from January 1 to November 3. Remember, the earlier slide that I showed you is only up to January 30 of this year. For morbidity week 44, yung leptospirosis cases is up by 94% na. Ayan, nandito po. 94% in terms of the number of cases. Now, we expect the heavy floodings to still haunt us in the coming years. According to the Pag-asa, heavy daily rainfall will continue to become more frequent, and extreme rainfalls is projected to increase in Luzon and Visayas only, but the number of dry days is expected to increase in all parts of the country in 2020 and 2050. And this is a picture of how Taft Avenue looks like after probably just Ilan ba, Ma'am Isa? 10 minutes of rain, di ba? Just 10 minutes of heavy rain, ganito na po yung itsura ng Taft Avenue. Okay? So, in terms of the summary of updates on the treatment recommendations, for my next few slides, I will just focus on treatment recommendations. Okay? Medyo mas madugo po kasi yung recommendation when it comes to diagnostics. But for treatment, okay, in terms of the updated guidelines, the main revision will be, we will be using the grade approach in terms of the evidence. Grade means grading of recommendations, assessment, development, and evaluation. And this is parallel with the rest of the PISMID guidelines. Kung mapapansin niyo po, yung mga PISMID guidelines na ginagamit natin ay grade. Diba? We grade the strength of the recommendation, whether strong or weak or conditional, and then we also evaluate the quality of the evidence, whether low, moderate, or high quality evidence. Okay? Now, for the update, articles published after the year 2009 will be included in the body of evidence to be used in the updated guideline. Remember that the most recent Lepto guideline was released back in 2010. And generally, the updates on treatment will be minor revisions on how previous revisions were stated. Now, clear recommendations on leptospiral diagnostics will remain to be a challenge, and there is still no perfect gold standard in terms of leptospirosis because most of the diagnostic tests for lepto is limited by the poor sensitivity, even the leptospiral culture. Yung cutoff titers that we use for our MAT, which is considered to be the surrogate gold standard, would need to be reassessed in the absence of seroprevalence studies. Is it 1:800? Is it 1:400? Or is it 1:1600? What should be the actual cutoff that we use for us to say that a patient, for a single MAT determination, ay positive for leptospirosis? And there are variable reports on diagnostic performances of the newer rapid diagnostic test in the absence of an ideal gold standard. Now, given the limitations of your available diagnostics for leptospiral species, and there is seemingly an abundance of data, madami pong research na ginagawa in terms of the symptomatology and signs of our local leptospirosis cases, a way forward would be to develop a modified local criteria, much like your modified FAINS criteria, which was developed, kailan ba, Ma'am Mears? 1970s? I don't know. This might be of a greater utility, especially for clinicians at the outset of the disease, but of course, such clinical criteria would have to be validated first before we can apply them in our own setting. And of course, evidence on adjunctive therapies in the treatment of complications will be evaluated, including immunosuppressive therapies, yung steroids, cyclophosphamide, and yung mga newer strategies such as ECMO. Now, this is just an example of how the statements will look like, the treatment statements will look like. All patients with suspected leptospirosis should be started on antimicrobial therapy regardless of the phase of the disease or duration of symptoms, and this is to shorten the duration of the illness, and also this is in the hopes of reducing the shedding of the organism in the urine of the patient. Now, remember that it may be argued that the efficacy of antibiotics in treating non-severe, yung mga mild cases of leptospirosis, is actually uncertain since acute mild leptospirosis usually resolves spontaneously. Most of the time, these patients will not consult us, di ba? The body, our own human body, is able to clear the feeble, the weak leptospires even without the administration of antibiotics. And in fact, yung complications of severe leptospirosis are actually caused not by direct invasion and direct destruction by your leptospires, but they are caused by immune-mediated reactions such as this. Okay? Yung cytokine storm of pro-inflammatory cytokines, particularly your IL-1 beta, IL-6, IL-12, your interferons, and your tumor necrosis factors. And this surge, this cytokine storm is followed by a paucity of your immune cytokines. Ang tawag doon yung immunoparalysis. Okay? Now, the knowledge on the clinical indicators of progression from an undifferentiated fever. Remember that most leptospirosis will start out as a patient presenting with fever na hindi natin alam na leptospirosis pala talaga yun, di ba? Pwedeng trangkaso lang pala, pwedeng dengue. Okay, so most of them will start out as undifferentiated fever. Now, yung progression nila to severe leptospiral disease, our knowledge about kung sino yung mga pasyente who will develop the severe complications is very limited. Okay? In this particular 2012 meta-analysis, which was published after the CPG 2010 was released, this involved all patients infected with leptospirosis, and the intervention here included yung mga studies that included were those that involve antibiotics expressly given for treatment of leptospirosis versus placebo, no intervention, or in comparison with another antibiotics. And this is a list of the primary outcomes that they tried to look at: overall mortality, leptospirosis mortality, even hospitalization, and down the line. The search was quite extensive. Okay, they were able to come up with 6 quantitative studies that they were able to include in the meta-analysis. In general, the included studies, low risk for bias except for randomization. But if you go back to the outcomes that we are trying or that they try to look at, those are actually objective outcomes. So medyo blinding is not really much of our concern, and this is a summary of the risk of bias of each of the studies identified in this particular meta-analysis. Most of these studies, maganda ang randomization and even the allocation concealment, and yung mga red bars, concerns about blinding lang naman. Okay, so what were the results? Primarily, the result was, in terms of days of clinical illness, this was the only result which achieved statistical significance. Okay? Yung pagbibigay ng antibiotics was actually resulted 2 to 4 days shorter among patients who received the antibiotics versus those who did not receive the antibiotics. But in terms of deaths, there was no significant benefit that was shown by the meta-analysis. Okay? In terms of comparing the different antibiotics, cephalosporins, yung cefotaxime or ceftriaxone versus penicillin, your doxycycline versus penicillin, azithromycin versus doxycycline, or even your cephalosporin versus doxycycline, the data is actually very limited, and so we are unable to come up with any specific recommendations kung ano ba talaga yung preference in terms of antibiotics. Okay? So, there's insufficient evidence on the use of antibiotics in preventing death from leptospirosis. However, the beneficial effects on the use of antibiotics on several clinically relevant outcomes have been deemed important. And examples of these clinically relevant outcomes include yung duration of clinical illness by 2 to 4 days. Remember, malaki matitipid ng pasyente natin kung madi-discharge natin sila, for example, 2 or 4 days earlier. And the relatively severe and possibly late leptospirosis patients may have increased dialysis when penicillin is used rather than placebo. Hence, I foresee that in the new guidelines, antibiotic treatment will still be recommended. In terms of what antibiotics will be recommended, I don't foresee any significant change in terms of the choice of antibiotics. For mild leptospirosis, it would still be doxycycline for oral and penicillin G for IV, and your alternative agents would include your amox, your azithromycin, and your IV agents would still include your ampicillin, azithromycin, ceftriaxone, or cefotaxime. Now, another statement is that antimicrobial therapy should be initiated as soon as a diagnosis of leptospirosis is suspected. Ibig sabihin, you don't have to wait for the results of your diagnostic test, laboratory examinations. As soon as your patient satisfies all of the criteria for a possible lepto, then you start your antibiotics right away. And this statement is actually published already in the 2010 guidelines, and the summary of evidence that they enumerated are the following. There was a cost-benefit analysis that has shown that a no antibiotic treatment strategy for suspected leptospirosis is not cost-effective because it would increase the cost of care resulting from complications in patients who were either misdiagnosed later on or who did not receive adequate treatment. And in a large case series involving 353 laboratory-confirmed leptospirosis patients in Hawaii from 1974 up to the year 1998, it showed that initiation of treatment within 2 days of diagnosis of symptoms was associated with a highly significant shortening of illness duration, and that the duration of illness was significantly shortened by a mean of 4.5 days among patients treated with antibiotics before 7 days compared to those patients treated after 7 days of onset of the disease. Now, there is a more recent study that is very similar to the result of this case series. Okay? This particular study, published by San Lazaro back in 2012, the population involved all hospitalized patients, okay, who had fever plus at least 2 other signs and symptoms of leptospirosis, a history of wading in flood water, which puts them at risk of developing leptospirosis, and symptoms occurring after the Ondoy outbreak. What they found out was yung patients who received antibiotics after 7 days from the onset of symptoms, merong increased risk of dying, okay? More than 7 days from the onset of the disease, okay? So, let's go back. Yung Leptospirosis CPG 2010 tells us of pre-exposure prophylaxis for leptospirosis and post-exposure prophylaxis for leptospirosis. It tells us that pre-exposure prophylaxis is not routinely recommended in those individuals who intend to visit highly endemic areas and are likely to get exposed. Then that's the time that you can initiate your pre-exposure prophylaxis. And when I tried to review the summary of evidence, this is a conditional recommendation with moderate quality of evidence. For post-exposure prophylaxis, ibig sabihin the exposure has already occurred, doxycycline is the recommended, still the recommended post-exposure chemoprophylactic agent for leptospirosis, and the duration of prophylaxis depends on the degree of exposure and the presence of wounds. And this is a strong recommendation based from moderate quality of evidence. Now, there was a 2010 meta-analysis that was updated in 2012, which was 2 years after the guidelines was published. The meta-analysis was entitled The Use of Chemoprophylaxis After Floods to Reduce the Occurrence and Impact of Leptospirosis Outbreaks. The outcome here was the development of leptospiral infection or clinical disease, and the initiation of pre- or post-exposure prophylaxis. And these are the studies that were included in this particular meta-analysis. For pre-exposure, for example, in the 2010 CPG, kasama po yung study by Seagal and Takafuji, and there were 3 additional studies that reported on the benefit of pre-exposure prophylaxis. For post-exposure prophylaxis, okay, ang mga bagong studies would be the 2010 study and the 2014 study by Jush Lee, and the two others earlier studies back in 2004 and 1998 were already included as part of the evidence, body of evidence for the 2010 CPG. Okay? And then there are other quantitative studies that were included in that particular review, particularly looking at the effect of post-exposure prophylaxis. And what is different in that particular study was it performed a mathematical model which it used to stimulate the evolution of a possible outbreak that would occur within 30 days. And this particular mathematical model showed or revealed that if you start your chemoprophylactic intervention at 5 days, it will actually result to a greater decrease in the number of patients developing leptospirosis compared, for example, if you start giving out your chemoprophylaxis at day 10. Okay? It's 84% if you start your chemoprophylaxis intervention on day 5 versus 77% if you start your chemoprophylactic intervention on day 10. And another result of this mathematical model is that if you increase the chemoprophylaxis rate at an earlier time, for example, 5 days compared to 10 days, then it will result to more cases of leptospirosis being prevented. So, what's the conclusion here? Oral doxycycline at a dose of 200 milligrams per week was still the most commonly used prophylactic antibiotic regimen. For pre-exposure prophylaxis, protective effect demonstrated for morbidity was demonstrated for morbidity and mortality, but there was unclear effectiveness in terms of developing clinical infection. And so there is a recommendation to use pre-exposure prophylactic doxycycline only for selected high-risk exposures and individuals. And for post-exposure prophylaxis, the direction of association is consistent across many studies included in this particular study, and this suggested a protective effect for reduced leptospirosis morbidity and mortality. And so, with the acceptable risk and the cost of doxycycline, then a post-exposure prophylaxis of doxycycline is being recommended. And in terms of the results of the mathematical modeling, chemoprophylaxis timing and administration rate are important factors in determining the change in the course of the outbreak. Now, how about immunosuppressants? We talk about cyclophosphamide and your steroids. Okay? Ang sinasabi ng Leptospirosis 2010 CPG, it states out the recommendation as this, something similar to this. Bolus methylprednisolone given within the first 12 hours of onset of respiratory involvement is life-saving in pulmonary leptospirosis, more so in severe disease. It reduces or delays the need for ventilatory support. And your steroid to be used is methylprednisolone, to be given at a dose of 1 gram IV per day for 3 days, followed by oral prednisolone 1 milligram per kilogram per day for the next 7 days. But look at the recommendation here. This is grade C. When you say grade C, it's for evidence to support a recommendation for or against the use. This was how they graded the recommendations back in 2010. Now, there are newer publications in terms of the use of corticosteroids in severe leptospirosis. In this 2014 systematic review, for example, that looked at high-dose corticosteroids involving several studies, okay, if you're going to look at the sample sizes, very limited. One is 8 gram dito, tapos the other one 62. And then there are other studies with high risk for bias. The conclusion of this meta-analysis is that there is really no recommendation that can currently be made based on clinical evidence regarding the use of corticosteroids in severe leptospirosis. There are reports of cyclophosphamide being used in pulmonary alveolar hemorrhage due to leptospirosis. For example, this one in India, if I'm not mistaken, okay, resulting to a higher survival rate among patients who received cyclophosphamide treatment. And the author's conclusion for this particular study is that cyclophosphamide is very useful in the treatment of pulmonary hemorrhage due to leptospirosis. And one of the foreseen side effects of giving your cyclophosphamide is leukopenia. This one, another study, plasma exchange with immunosuppression using your cyclophosphamide, also have shown some increase in terms of survival. Yung mga nakatanggap daw ng cyclophosphamide regimen had increased survival rates up to 61.4% compared to those who did not receive the cyclophosphamide. The survival rate is just at 16.6%. But then again, this study has a high risk of bias. The author's conclusion of this particular study is that plasma exchange together with your cyclophosphamide may be useful to treat mild cases of pulmonary alveolar hemorrhage, and leukopenia was again a common adverse reaction in the treatment group. Now, let's try to go local. The National Kidney and Transplant Institute has tried to come up with several publications reporting their experience on cyclophosphamide. Just a quick history. During the 2009 Ondoy outbreak, leptospirosis cases in NKTI were found to have high mortality rates at 26%, and I think they were not happy about this. Kaya they were trying to look for ways on how to improve mortality rates. They tried to incorporate the use of hydrocortisone into their policy. Still not happy with the results, kaya they tried to shift to using yung methylprednisolone plus cyclophosphamide. If I'm not mistaken, Ma'am, Dr. Mendoza, parang ganun yung quick history of it. Okay, so these are just some of the publications that they were able to come up with. This was entitled Effect of Methylprednisolone and Cyclophosphamide on the Survival of Patients with Leptospirosis, Renal Failure, and Pulmonary Hemorrhage altogether. They compared hydrocortisone and methylprednisolone, and this is a retrospective review. Okay, so they tried to look at the outcomes of patients who received hydrocortisone only, and these were patients given hydrocortisone from September 1, 2009 up to October 24, or from October 24, 2012 to September 1, 2009, compared it to those who received the methylprednisolone cyclophosphamide group from August 25, 2012 up to August 21 of 2013. And what they found out was there seems to be an increased survival, okay, decreased deaths among patients who received the methylprednisolone cyclophosphamide combination, okay, 88% and 74% respectively yung kanilang survival rate. Okay? And among the patients who died, okay, yung death because of pulmonary hemorrhage for those who received hydrocortisone accounted for 88% of these deaths. And for those who received the methylprednisolone cyclophosphamide group, death due to pulmonary hemorrhage accounted for 88%. Okay, it's more or less similar. Most of these deaths, their mean platelet count was lower than 100 compared to those who did not die. Okay, those who survived. Okay. So they also noted that after treatment, yung partial thromboplastin time of patients who received the MPC or methylprednisolone cyclophosphamide treatment is actually lower. And so their conclusion was that the 3-day course of methylprednisolone plus a single dose of IV cyclophosphamide significantly improves survival among patients with leptospirosis, renal failure, and pulmonary hemorrhage. But take note of the population here, okay? Leptospirosis plus renal failure and pulmonary hemorrhage. There was significant improvement in the levels of APDT in patients who received the methylprednisolone cyclophosphamide therapy. And in another publication, okay, that looked at survival, okay, so same, okay, majority of the patients who received the methylprednisolone cyclophosphamide therapy survived, and there was only a 25% mortality rate, and some of the predictors of mortality that they were able to identify are the following: a low platelet count, deranged ProTime, abnormalities in the chest X-ray. Okay. The conclusion of this study was that 25% mortality among patients diagnosed with leptospirosis with renal failure treated with pulse immunosuppression, with majority dying of pulmonary hemorrhage. So again, these are patients with renal failure and pulmonary hemorrhage, severe complications of leptospirosis. Thrombocytopenia, prolonged ProTime, and infiltrates on chest X-ray were the predictors of mortality identified in this study. Okay. So the proposed revision for the upcoming guideline would be something similar to this one. It will be stated as steroids have been reported to reduce or delay the need for ventilatory support, improve PTT or mortality among patients with leptospirosis at risk of pulmonary hemorrhage. If there is a decision to use steroids for such patients, it should be initiated as soon as the first signs and symptoms of pulmonary leptospirosis or pulmonary manifestations are detected, such as tachypnea, hemoptysis, and dyspnea, and the following regimens have been used. Okay, that's methylprednisolone at this dose, 1 gram IV per day for 3 days, to be given. The first dose is to be given as a bolus within the first 12 hours of onset of respiratory involvement, followed by your oral prednisolone. And for those with renal failure, then that's the time that you can try out your methylprednisolone plus cyclophosphamide regimen. How about your ECMO? ECMO is a form of a cardiopulmonary life support where blood is drained from the vascular system. This is circulated outside of the body by a mechanical pump, and then you infuse your oxygen while removing your carbon dioxide. Okay? A bit costly, okay, and not readily available. Ma'am Mirna, you have how many units of ECMO sa NKTI? Meron ba? 2? You have 2? Okay? And these are some of the indications for respiratory support, for ECMO. Okay? There have been documented case reports of survival following the use of ECMO. Okay? Including those affected by leptospirosis. Okay? There's one in 2015, another one in Japan in 2017, and another one in Chile in 2017. And these are the ECMO days, 6, 11, and 8 respectively. But what can we say about ECMO? Well, it's a promising novel adjunctive strategy that can be used in the treatment of patients with severe complications of leptospirosis. But experience is limited to make any recommendations for its use at this point. Okay, I think that's it. I'm down with my last slide. A few shameless plugs. I would like to invite everyone for next year, June 4 to 7, 2019, RIT and ID Week and 11 postgraduate course somewhere sa Mountain Trails of Alabang, one of the hotels there. And of course, sa Crown Plaza, FIX 25th anniversary, PILA, FIX Ilaw sa Larangan ng Aghamat Kalusugan on May 23 to 24, 2019. at the Crown Plaza Galleria, Manila. Thank you very much.
Thank you, Dr. Roman. So let us call our second speaker to talk on the clinical practice guidelines on adult immunization. May we call to the stage Dr. Claro Raymundo O. Antonio.
Alright, good afternoon everyone. So this is the last leg for this updates on clinical practice guidelines. So in behalf of the technical working group, they are here with me in support, in spirit and in physical. Thank you very much for creating this very taxing clinical practice guidelines. So we've been doing this for 2 years now and still keep updating, and we will try to update again, but I'm not sure how soon is soon. But I will now present to you the 2018 Clinical Practice Guidelines for Adult Immunization. I think next week we will provide a PDF copy of this in the TSMID website, so you can check the website frequently for any updates regarding the availability of this CPG for adult immunization. Now for disclaimer, the details of this slide deck is the property of PSMID and is protected by the Philippine copyright. So anyone who would like to use this slide deck or this material should ask permission from the PSMID with this contact, with this email address. Okay. So for the objective, at the end of this presentation, each and every one of us should know the updates on the immunization and apply the latest principles on vaccination. So for this afternoon, I will discuss the executive summary of the general principles and the timing, the dosaging, and some of the precautions in giving or administering vaccines. And at the same time, the vaccine safety, categorization of the adverse events following immunization or AEFI, and the list of reportable serious events. And I will just tackle on 5 updates on these specific vaccines, which is your Hepatitis B, Herpes Zoster, influenza, HPV, and the pneumococcal vaccine. Now, for the executive summary, this is an update of the 2012. So from 2012, we updated the CPG to the latest 2018 with the implementation of the grade system that was, I think, mentioned by Dr. Dessi a while ago. And there are 17 total vaccine-preventable diseases, which will tackle only on immunocompetent adult Filipinos, some immunocompromised patients. There will be some recommendations in some of the vaccines that I will discuss later on. There are clinical questions on how effective and how to, or when or to whom should you give the vaccine. Those are also included in the CPG guidelines. Recommendations is only limited to Philippine residents or Filipino patients, and the format of the CPG is also revised. Now there is some new information on the simultaneous vaccination, which is later I'm going to define. There is now a recommendation for the 4-day grace period, especially if you are giving in multiple doses of vaccines. Live vaccines and antibody-containing products should not be administered simultaneously. Otherwise, serologic testing should be done in these cases. There will be also interchangeability of single-component vaccines. If, for example, you're using a specific vaccine that has different brand names, okay? There are enhanced definitions for the precautions, what are the contraindications and the precautions. vaccination in hospitalized patients, and the discussion about patient safety. So these are the great recommendations. I will not tackle those one by one. We will now proceed on the general principles of vaccination, particularly your timing and spacing of vaccines. Now, to optimize the maximum benefit of the vaccines, the recommended schedule should be followed as closely as possible. Vaccine doses should not be administered at intervals less than the minimum intervals. The dosing or the administration of the doses too close together or too young at age can lead to suboptimal immune responses. Vaccine doses, if administered less than 4 days prior to the minimum interval, are actually considered now valid. Alright? And this is now termed as your grace period. However, this 4 days grace period guideline is not applicable in rabies vaccine schedule. So you have to stick to the rabies vaccination scheduling. So the doses of any vaccine more than 5 days earlier than the minimum interval is not actually counted as a valid dose, and it should be repeated as age appropriate. So the repeat doses should be spaced after the invalid dose by the recommended minimum interval. So kung for example is mapaaga mo ng more than 5 days ang ating with the minimum dosage recommended na interval, so you should actually repeat the dosage as age appropriate. Now, how about simultaneous administration? For the definition of simultaneous administration, it is defined as administering one vaccine on the same clinic at different anatomic sites, but not in the same syringe. Okay, minsan ginagawa kasi no? Yung isang syringe, ano na lahat ng vaccine, no? But when you say simultaneous administration, you give more than one vaccine on the same clinical day and you give it at different anatomic sites, no? Now, what is the rationale behind this? You can actually simultaneously administer all your vaccines for which a person is eligible at the time of visit. Now, this will actually increase the probability that the patient will benefit from the vaccinated and that he or she will be vaccinated fully. With some exceptions, same-day administration of widely used vaccine, live or inactivated, does not diminish the seroconversion rates when vaccines are given at the intervals less than these minimum intervals. Okay? So, sorry. Okay, how about the non-simultaneous in inactivated vaccines? There is no evidence that the inactivated vaccines interfere with the immune response to other inactivated vaccines or to your live vaccination, such as your MMR. So any inactivated vaccine can be administered either simultaneously or at any time before or after a different inactivated or live vaccine. Except for, there are two exceptions, are a 4-week interval between your PCV13 and a meningococcal vaccine. This is in persons with anatomic ischemia, and the separation of doses between these two vaccines around 6 to 12 months recommended for non-high risk, or 8 weeks minimum if the patient is immunocompromised. How about for live vaccines? 2 live vaccines can be given or can be administered on the same day. Otherwise, if the live vaccines should be separated by at least 4 weeks para ma-minimize the potential of having risk for the interference. Now, if 2 vaccines are separated by less than 4 weeks, for example, nabigay mo 2 live vaccines na wala pang 1 month, the second vaccine should not be administered, and if the second vaccine administered should not be counted, and the dose should be repeated at least 4 weeks later. Alright, so you give, if napaaga yung isang dose, then you give another dose sa susunod na dose, which is dapat 4 weeks later. So the 4-day grace period discussed earlier may be shortened to minimize the interval. So you can give live vaccines on the same day. Now, how about issues on giving vaccinations and blood transfusions or any antibody-containing products, no? For example, like blood. If you are giving inactivated vaccines, it actually has no or non-significant interference with your antibody-containing products. So by giving inactivated vaccines and toxoid, if either you give this simultaneously or together with the blood product, okay lang yun. However, there should be an interval if you give a live attenuated vaccine from prior to the administration of an antibody-containing products. You should consider those things. For example, in this slide, if a patient received a packed RBC, in such dose, you should give your MMR or your varicella-containing vaccine 6 months after the transfusion, so on and so forth. Now, other issues about timing and spacing of the vaccines, about the interchangeability of single-component vaccines from different brands or different manufacturers. So vaccination should not be deferred because the brand use of the previous doses is not available or hindi alam kung meron pa bang availability. So any FDA-approved vaccine brand may be used to continue or to complete the series. Okay. How about extended intervals? So it is not necessary to restart the series of any vaccine due to extended intervals between doses. However, for oral typhoid vaccine, the series should be repeated if the 4-dose series is extended to more than 3 weeks. How about the issues about number of dosing? So inactivated or live vaccines, they generally require multiple dosing and may require periodic boosting based on the recommendations that we are going to present for these CPG guidelines. Okay? And for mixing, unless licensed for mixing, individual vaccines should not be mixed in the same syringe. Right? So kung sila paghahaluin, to give them a different anatomic size. How about contraindications and precautions? Now to define these two, for the contraindication, this is a condition wherein the recipient increases the chance of serious adverse events, so therefore hindi mo kailangan ibigay, no? As compared with precaution, it is defined as a condition wherein the recipient may increase the chance or the severity or increased severity from an adverse event, might cause diagnostic confusion or might compromise the ability of the vaccine to produce immunity. Okay. Now, there are permanent and parang absolute contraindications to vaccination, and these are the following. If the patient presents with severe allergic reaction to a vaccine component or following a prior dose, or if the patient developed encephalopathy not due to other identifiable cause occurring within 7 days of pertussis vaccination. So these are the permanent contraindications to vaccination. Now there are some invalid contraindications or parang paniniwala na these are the invalid contraindications. No? Generally, it applies to all vaccines, and these are the conditions that are more commonly perceived as contraindications to precautions. Like for example, mild or acute illness or fever, alright, those are perceived as contraindication. Mild to moderate local reaction, low-grade to moderate fever, lack of previous physical examination, current antimicrobial therapy. So, hindi totoo, no? But in conditions wherein you are planning to give patients with PY21A oral typhoid vaccine, antibacterial drugs might actually interfere. There are certain viral medications that might interfere with your varicella-containing vaccines and NIAV4. Okay? Convalescent phase of illness, hindi po totoo. Preterm birth, no? So, in patients na preterm birth, like for example, Hepatitis B vaccination, you can defer giving Hep B vaccination in preterms weighing less than 2 kilograms if the mother is HBsAg negative. However, if the patient is born, regardless of the birth weight, to a mother that is HBsAg positive, the Hep B immunoglobulin plus your Hep B vaccine should be administered within 12 hours after birth, regardless kung siya ay less than 2 kilograms. Okay? Recent exposure to infectious diseases, that's not true, and history of penicillin allergy, other non-vaccine allergies, or if they have relatives with allergies or receiving allergen extract immunotherapy, you can still give the vaccines, no? And history of Guillain-Barré. So an exception is Guillain-Barré. If, for example, you are giving within the 6 weeks, you are planning to give dose of influenza and tetanus toxoid, because these tetanus and toxoid and influenza-containing products actually might pose harm for these patients within the 6 weeks of patients with Guillain-Barré syndrome. Now for vaccine safety, now there are certain terminologies about the minor, severe, and serious. For the minor adverse events, it occurs within a few hours of injection and then resolves spontaneously after a short period of time. Severe adverse events are termed as results from a long-term problem. Serious adverse events are caused by the potential risk of health or life of a recipient due to a hospitalization, disability, and even birth defect or congenital anomalies. Alright, now there are some definition of your AEFI, adverse event following immunization. It can be vaccine-related, or immunization-related, or sometimes it can be inconsistent with some of the associated causation. Like in this vaccine-related, the AEFI might be product-related if the cause is precipitated by the inherent properties of the vaccine itself. No? So for example, nagkaroon ng lip swelling after an injection, maybe because due to the inherent property of the vaccine. Or it can be quality defect-related reaction. For example, ang nabiling vaccine is ibang itsura ng vaccine. For example, may defect doon sa needle, that caused or precipitated an adverse event, then that is quality defect-related reaction. In immunization-related adverse event, this can be number one, error-related. For example, inappropriate vaccine handling, or for example, administration. Yung mga, kunyari, hindi naging sterilized yung hindi ka nag-sterilize ng area, nagkaroon ng reaction, so those are error-related. It can also be anxiety-related. For example, if the patient is anxious about immunization, and then nagkaroon ng vasovagal syncope because of the immunization. So those are anxiety-related adverse reactions. And there are also coincidental event that is the outcome na hindi naman ina-expect. No? For example, a fever that occurs at the time of vaccination, but is in fact actually caused by another disease entity. No? So those are just coincidental event. Okay. Now, these are the onset or time interval that you should do when reporting adverse event following immunization. No? If you encounter a patient with anaphylaxis or toxic shock syndrome or anaphylactic reaction, you should report this AEFI within 24 to 48 hours of immunization. If the patient develops sepsis or injection site abscess, or severe local reaction, then you can report it within 7 days of immunization. So, seizures, febrile seizures, or encephalopathy within 14 days, paralysis within 3 months, disseminated osteomyelitis, lymphadenitis within 1 to 12 months. If the patient is namatay yung patient, or hospitalization, or developing disability, or any severe and unusual events, then wala. Walang no time limit. Alright, so I will now proceed with the hepatitis B, first with the hepatitis B virus vaccines. Currently, the available preparations that we have right now are the two, which is your monovalent recombinant Hep B and the combined inactive Hep B and Hep A vaccine. So usually the recommendation is to give the vaccine for the prevention of an HBV infection in high-risk individuals. For our first recommendation, Hep B vaccine is recommended in the prevention of HBV infection in high-risk individuals. This is with strong recommendation but very low quality of evidence. Number two, Hep B vaccine may be recommended in the prevention of HBV infection in unexposed low-risk individuals. So we are stressing the importance of high-risk individuals that will be more beneficial than those patients who are low-risk or unexposed. This is big recommendation but with very low quality of evidence. Hep B vaccine should be routinely administered to patients with chronic renal failure. This is a strong recommendation but with very low quality of evidence. A reinforced vaccination should be given to patients with chronic kidney failure with strong recommendation and low quality of evidence. Patients with HIV, they should receive the Hep B vaccination. This is a strong recommendation, although with a very low quality of evidence. Hep B vaccine showed to promote para increased antibody titers, no? In a protective, at a certain protective level, no? Although the term is not that very long, it is just a short benefit for these patients since they're having problems with their mounting of these immune responses, no? But it was believed and it was proposed that together with the ARV medications, this protection might be prolonged, especially if it is compounded with an additional ARV medications. So most of the patients who receive HPV medications, the level of protection over time might wane off, especially if the patient is not receiving ARV medications. Now, a booster dose may be given to healthy individuals 5 years after the primary vaccination schedule for the prevention of the HPV infection. But this is a very weak recommendation with a very low quality of evidence. This is based on the study of Portadai, there are studies there are some recommendations or studies, randomized studies, clinical trials, but they reviewed the need for the Hep B vaccination for healthy individuals, no, na merong normal immune status, na nagkaroon ng response from the vaccine, no. However, these randomized trials were not eligible, no, and at the same time, when the technical working was able to review it, they were not compared with the control group, no. So the clinical consequences of offering these booster doses to a healthy individual, no, medyo hindi pa siya recommended. So in principle, there is no, in principle, and with these available trials, no, we still need such recommended clinical trials to support this recommendation. But yes, we may give it to patients with healthy individuals, but with a very low quality of evidence. So vaccination has a clear effect, no, on the risk of developing HPV infections in participants without previous knowledge of HPV infection. So we're trying to stress out that those patients with high risk are those who will benefit this vaccination. So the high risk involves the patient has continuous exposure to blood products, blood-contaminated instruments, body fluids or tissues, medical students, medical practitioners, prisoners, healthcare workers, and drug users. Now, about the scheduling. The standard schedule is 3 doses, wherein we give it on 0, 1, and 6 months. No? Same as with the combined vaccine for Hep A and Hep B. However, there is a recent recommendation about the accelerated scheduling. And this is to achieve an accelerated level of antibodies, especially for those individuals na high risk. No? It was emphasized in the studies for this accelerated scheduling that seroprotection rates, okay, is in the accelerated group or accelerated dosing at the first, as comparing to your standard group, no, during the first and third month after the initial dose, no, it was non-inferior, no. However, nagkakaroon ng difference over time. Because it was found out that those patients receiving the standard schedule of the doses have actually sustained levels of antibodies over time as compared to your accelerated. No? So if you want an immediate response or protection from hepatitis B, especially if you are a high-risk individual, you can give the accelerated schedule. But ang caveat nandito is ang kanyang antibody levels or protection is hindi ganun ka-sustain as compared to the standard dose. So the recommendation here is you can give a booster dose a year after of your accelerated schedule. Or if you want to check your HPS titer, then you can give another dose if the level is below 10. No? And this is actually anong recommendation ba natin? Ayan. So just like what I've said, no, so zero protection rates with accelerated group, right, is mas maganda kanyang ang kanyang protective level over time. And you might want to give booster dose if you are giving the accelerated dose. Now, for hepatitis B virus vaccine, these are the common adverse events: pain, redness, and soreness. Contraindication to the vaccine if there's hypersensitivity. Okay, and it should not be administered to subjects with moderate to severe acute illness with or without fever, and not evaluated for pregnant patients based on the clinical studies. Now, for herpes zoster vaccine, we have two available vaccine for these. We have the live attenuated and the adjuvanted recombinant, or the RZV. We still don't have this adjuvanted sa Philippines. I'm not sure kung kailan. I think next year, magkakaroon. So, the live attenuated, it contains the same live attenuated virus, but it has over 14-fold more plaque-forming units. Okay, and it activates a specific T cell production, increasing the immunity. As compared to the adjuvanted, it has a 50 micrograms of your recombinant VZV, glycoprotein, right, and formulated with this following adjuvant system. Okay, for the recommendation, for the herpes zoster live attenuated vaccine, the herpes zoster live vaccine should be given to immunocompetent adults more than or equal or more than 60 years old if they have without prior history of herpes zoster to prevent disease. No? So, although the vaccinated group had a reduced incidence of herpes zoster, okay, pero hindi masyadong common actually ang recurrence of the herpes zoster in immunocompetent individuals. No? And at the same time, the recommendation is for the ASIP is you have to give it in more than 60 years old. No? There are some, the 50 to 59, hindi pa masyadong nire-recommend unless there are some studies that can actually validate for its safety. So for right now, the recommended is still more than 60 years old. No? Herpes zoster may be given to immunocompetent adults more than 60 years with prior history of herpes zoster infection to prevent the recurrence of disease. Okay, this is supported by the observation that the recurrence of the herpes zoster is not that very common, no? But there was a trend toward the incidence of having lower recurrence in patients vaccinated with the vaccinated group as compared to those who were not vaccinated. Now, for the recombinant adjuvanted, ito yung lalabas dating sa atin, you can now give it in patients more than 50 years old. Okay? So, for the live, it's more than 60. If for the recombinant adjuvanted recombinant, you can give it is more than 50 years. No? So based on the ECIP grade findings, no, vaccinating these patients at more than 50 will prevent the disease recurrence or even the disease itself in midlife, and it actually can sustain them protection over 4 years. No? So this may be irrespective if the patient already received the vaccine before, alright? So, or for example, hindi alam kung nagkaroon ng varicella before, so it is recommended na pwede mo silang ibigay, no? And the vaccine efficacy for this is around 96.6%. The recombinant adjuvanted is preferred over the live attenuated for the prevention of herpes zoster and related complications. Now, what are the schedule? All right, for the live attenuated, it's just a single dose. For the recombinant adjuvanted, you can give it 2 doses intramuscular, that is 2 to 6 months apart. The common adverse events as follows. Contraindication is if the patient has known anaphylactic reaction to any vaccine component. Now, for the live attenuated herpes zoster, the vaccine efficacy for this in these clinical trials are as follows. In 50 to 59, it's around 70%, and 60 to 69, 64, alright. Although, gaya nga nasabi, the recurrences in this population is not that common, but the trend is towards benefit pa rin, no? And it also has a benefit in patients to preventing post-herpetic neuralgia over 60 years old with 65.7 and 68.8% with this age group. Ayan. So this table just tells us that over time, years after giving the initial doses of your live attenuated, which is a single dose of your vaccine, the vaccine efficacy will wane over time. Okay? Ang tolerance nila dito that they see, that GMT levels at the same time translated to vaccine efficacy is around 4 years, no? Around 44.6 vaccine efficacy can serve as a protective level for these patients, especially in patients more than 60 years old. Now, while repeated zosters has been confirmed in immunocompetent, and the actual risk of recurrence has not firmly established because it is not common. So the benefit of vaccinating immunocompetent patients who have had shingles has not been systematically examined. So wala pang with the immunocompetent patients without previous history of shingles. Okay, now for the influenza vaccine, we have two preparations in the Philippines. So we have the PIV or the trivalent, which contains two influenza A strains, alright, covering these two strains of your influenza vaccines. However, in the quadrivalent, it contains 4 influenza surface antigens, right, from these two viruses. The scheduling is annually, and the severe allergic reaction is one of the contraindications, and precautions is yung sa Guillain-Barré syndrome, right? Yung so within 6 weeks. Now, for the first recommendation, inactivated influenza vaccine is routinely recommended in preventing influenza and influenza-like illness in immunocompetent adults. This is on a yearly basis, no? This is based from patients who received vaccinations and who underwent surveillance in preventing clinically or laboratory confirmed influenza with a vaccine efficacy of 60% and a number needed to vaccinate of 71 subjects. For the second recommendation, the use of inactivated influenza vaccine versus placebo is effective in preventing the occurrence of influenza or influenza-like illness. However, there is no benefit as to preventing mortality for the elderly population. And this is a strong recommendation with moderate quality of evidence. No? So, ang sinasabi dito sa mga studies with, from these trials, no, that although the inactivated vaccines has a vaccine efficacy, or has a great vaccine efficacy in preventing influenza and influenza-like illness in the elderly, but it doesn't show any benefit in mortality, in preventing mortality. Third recommendation, influenza vaccine may be given to patients with cancer to prevent all-cause mortality and pneumonia. You may give this because it has a weak recommendation with low to moderate quality of evidence. Isa to sa mga bagong recommendations. Why? Because the influenza vaccine has no clear benefit among cancer patients. No? Maybe because of the immune dysfunction, because of the malignancy, or maybe because of the chemotherapy that these patients are receiving that might interfere with the activity of your vaccine. So for cancer patients, there is no clear information on the importance, the need, and the safety of giving this vaccine. You may give this vaccine, although ang caveat dito is you have to carefully consider this evidence, that there are no clear effectiveness in cancer patients. Influenza vaccine should be administered to patients with HIV of CD4 count with more than 100 cells to prevent laboratory-confirmed influenza. Again, laboratory-confirmed influenza. This is a strong recommendation with moderate quality of evidence because in a study, in a recent systematic review of 1,500 patients, HIV-infected individuals with more than 100 cells has a vaccine efficacy of 85% to prevent laboratory-confirmed, but not in influenza-like illness. No? It doesn't have any benefit in influenza-like illness for the prevention of influenza-like illness, mortality, and hospitalization. No? By the way, all of the RCTs that were included in this from the technical working group, it was reported that the predominantly circulating virus na reported in these studies are actually the same virus that is respected in the vaccine that is being investigated. The fourth recommendation, to prevent influenza-related respiratory infections and hospitalization, influenza vaccine should be given to patients with bronchial asthma, COPD, and cardiovascular disease. And this is a high recommendation with moderate to high quality of evidence. No? It was found out that if you give patients influenza vaccine on a yearly basis in patients with asthma, okay, it will shorten by 2 days yung kanila exacerbation as compared to those patients who were just given placebo. Influenza vaccine may be given to patients with end-stage renal disease. You may give this to them, but this is actually a weak recommendation with very low quality of evidence. Kasi there is only very low quality of evidence because Because based from this table, in ESRD patients, the vaccine efficacy is only 12%. No? Now, the outcomes to prevent influenza-like illness is very low. That's why a weak recommendation with a very low quality of evidence is posed. However, ito yung summary niya, no? In ESRD patients, the vaccine efficacy is very low, but in patients with bronchial asthma, the efficacy is actually 98%, okay? Including your laboratory confirmed influenza-related asthma exacerbations, that the influenza vaccine can prevent these outcomes. In COPD patients, the vaccine efficacy to prevent exacerbations is around 73%, while the efficacy for hospitalization due to influenza-related exacerbation is around 67%, both having strong recommendation with moderate quality of evidence. Now, for cardiac patients, cardiovascular death from influenza-like related illnesses can prevent it. This vaccine can prevent at around 55%, with strong recommendation and high quality of evidence. For the HPV vaccine. Now, these are the available vaccines that we have right now. Ang naunang dumating sa atin is the Cervarix, the bivalent, which contains the following VLP, or the virus-like particles, and quadrivalent vaccine with the branding of Gardasil, with these following coverage. And right now, meron na po tayong nonavalent, or the 9-valent vaccine, branded as Gardasil 9, with additional 5 virus-like particles, and with the following manufacturers and their dose and their volume per dose. Now, the first recommendation is it is effective in preventing cervical cancer. This is for the bivalent vaccine. Okay, you can use your bivalent vaccine, and it is effective in preventing cervical cancer associated with HPV 16 and 18, which is common among immunocompetent adult females and can be given until 26 years old, with a strong recommendation and high quality of evidence. Now, for the quadrivalent and nonavalent vaccine, both are also effective in preventing cervical and anogenital warts among immunocompetent adult females and can be given until 26 years old, with strong recommendation and high quality of evidence. And for males, it may be given to adult immunocompetent males from ages 16 to 26 for the prevention of anal cancer and genital warts. Bakit walang recommendation for bivalent vaccine in males? Kasi wala pong trial. Puro immunogenicity trial lang for males. No? So wala pong parang vaccine efficacy trial for males or outcome for males in preventing anal cancer for the bivalent vaccine. Now, for the summary, these are the available vaccines and their vaccine types. No? HPV type 16 was the most common HPV type in women with cervical squamous cell carcinoma, followed by 18, 45, 52, and 21. On the other hand, the most common HPV type for females with cervical adenocarcinoma or adenosquamous carcinoma is 18, 16, and 45. No? In anal cancer, which is also prevalent in males then, the most common is HPV 16, no? Followed by HPV 18. However, dito sa atin, sa Philippines, wala tayong local data about the prevalence of HPV cases among anal cancers, lalo-lalo sa males, no? But there was a latest study by Dr. Mojica from, I think this is from PGH, no? Who evaluated 11 PDS institutions, the Philippine Dermatology Society institutions, about the anogenital HPV cases over time. Still, mas marami ang males as compared to females, with increasing rates over time. Now, for the summary of evidence. Now, there was a study on Asian population wherein they recruited 16,000 Chinese women 18 to 25 years old, and they found out that the vaccine efficacy of a bivalent HPV vaccine to prevent your CIN infection and even 6 months persistent infection is actually at 94.2%. So meron kang protection from this even 6 months after your vaccination. This is further substantiated by a multi-center randomized trial, and at even 72 months after your vaccination, okay, that the vaccine efficacy is showed around showed at around 87.3%. No? This is for the bivalent vaccine. For the quadrivalent, these both vaccines actually can protect you from the HPV 16 and 18, which is common. Na meron naman silang dalawa, no? That causes majority of our cervical cancers and other malignancies that are HPV associated. So your 9-valent vaccine covers your additional 5, no? Which is your 31, 33, 45, 50, 28, no? And this accounts actually maliit lang 15% of your cervical cancers. However, in a randomized clinical trial, if you compare the quadrivalent and the non-valent vaccine in these female patients recruited in mga 14,000, no, there was a vaccine efficacy of 96.3%. No? Actually, not inferior din siya with your quadrivalent vaccine in terms of their coverage. But in terms of coverage for these additional 5 serotypes, has actually a benefit of around 96.3%. Now, the ACIP recommends that the vaccine series for the non-valent and quadrivalent vaccine may be given at age 9. But it can be extended, or actually it can be given in females from 30 to 26. Yun pala po yung data na meron sa atin. This is the recommendation so far right now of the ACIP. Okay? Even those who have not been previously vaccinated or have not completed the 3-dose vaccination. Okay, so what are the recommended dosing? For the bivalent, you can give it at 0, 1, and 6. For the quadrivalent, you can give it at 0 or 1 to 2. Sa guidelines namin, ang nilagay namin is 0, 2, and 6. Alright? And you have to give it by intramuscular injection in the deltoid area. So if the vaccination providers or the healthcare workers do not know or walang idea about the or do not have the previous HPV product that was administered, or for example, not the transition of patients from quadrivalent to monovalent, okay? So pwede mo na mag-gamitin yun, especially if your concern is the 16 and 18 na HPV types, no? So the monovalent or the quadrivalent vaccine may be used, okay, to complete or to continue the series. However, wala tayong data if we can give the monovalent vaccine at fewer doses, less than 3 doses. So the recommended parent is the 3 doses. Also, there are no current recommendation for additional monovalent vaccine for those who have previously completed your quadrivalent vaccine. Bakit? So for example, if a patient already received the bivalent and the quadrivalent, tapos gusto nila magbigay ng additional doses for the monovalent, there are no recommendations pa from ACIP. Because these additional 5 serotypes in clinical practice, hindi ganun ka-common. Ang types natin, especially in squamous cell carcinoma and anogenital wart types, no? So, especially in males, right? So, but either way, you can give the quadrivalent and the monovalent vaccine, especially in males, recommended for the prevention of your anogenital warts and other cancer-related malignancies from these serotypes. Okay? For the pneumococcal vaccine, so the latest, these are so as we know, Streptococcus pneumoniae, it can cause upper and lower tract infections and other serious infections. There are 2 types of vaccines in the Philippines right now. So you have the PPSV23 or the pneumococcal polysaccharide, no? And the PCV13 or pneumococcal conjugate vaccine. These vaccines are serotype specific to cover the frequently associated serotypes that can produce severe illnesses, such as this, the PPSV23 and PCV13 for this coverage, plus with this as well. So, based from the local study by Dr. Capeding et al., there was a laboratory-based surveillance. So they found out that these are the most common serotypes in the Philippines. So, meron tayong coverage for this and this, okay? 16, 60, 14, so on and so forth. For the first recommendation, PPSV23 and PCV13 can be administered routinely to immunocompetent elderly patients to prevent invasive pneumococcal disease. And this is with a strong recommendation with a moderate quality of evidence. Now, for the following recommendations, for the following outcomes that I'm going to present, there are no actually head-to-head comparison with PCV13 and PPSV23. So for example, in the outcome of pneumonia, walang head-to-head comparison between the PCV13 and the PPSV23. So I'm going to discuss the outcomes individually if you give the PPSV23 and the PCV13 and their evidences. Okay, so for the invasive pneumococcal disease, the pooled results of the randomized clinical trials, okay, they assess the PPSV, okay, this is the meta-analysis, and this is the single RCT of the PCV13 trial na ginawa. This is a large clinical trial with 84,000 patients, no? Evaluating PCV13 with the following outcomes. For the invasive pneumococcal disease, right, the random clinical trial showed that the odds ratio is 0.51 with a very short, with a very narrow confidence interval. And this is supported that it can reduce your invasive pneumococcal disease for any pneumococcal strain. As compared to your PPSV, which has an odds ratio of 0.26, however, with the heterogeneity of the following, okay, with the following number of patients. For the PPSV23, it can be administered routinely to immunocompetent adults, especially in the elderly, in preventing pneumococcal pneumonia, with a strong recommendation and low quality of evidence. So how about your PCV13? Okay, so the PPSV23 has low quality of evidence for this. However, it has a strong recommendation from the panel. And the PCV13 actually has a good recommendation or evidence for prevention of the pneumococcal pneumonia. If we are going to look at the study of the pneumonia outcome in patients given PPSV, it's because of the high heterogeneity of this study in this meta-analysis. No? However, if you will see, the PCV13, although with the odds ratio of 0.95, it has a very wide confidence interval. However, when they did the sub-analysis of this study, patients with pneumonia that are vaccine types, with the vaccine type strains based from the PCV13 coverage, no? In the same study, the odds ratio of the PCV13 is around 0.61 with a very narrow confidence interval, and this supported the benefit of your PCV in preventing pneumonia, especially those caused by your vaccine type strains. Now, for the PPSV23 and PCV13, they are recommended, they may be recommended for immunocompetent adults, especially in the elderly, in preventing mortality, no? Although with a very low quality of evidence, but with a strong recommendation from the panel. If you will see, it's because of the high heterogeneity of the study from the PPSV, and at the same time, because of the wide confidence interval of your study from the PCV13 randomized clinical trials. PCV13 may be given first, followed by PPSV23, at least 1 year after the PCV13 dose. No revaccination with PPSV23 nor PCV13 is needed. So there was actually a study about this, yung pagbibigay natin ng dosing for the PCV and PPSV. No? It is the opsophagocytic activity or the OPA. It was found that if you give PCV13 first before the PPSV, the response or the functional response of the immune system is better, with better OPA as compared to those patients who received the PPSV first, followed by your PCV13. Subjects who received first the PPSV23 has lower OPA responses, and as compared to those who were given your PCV13. No? Adult Filipinos, more than 50 years of age, who were previously given PPSV23 may be given PCV13 vaccination at least 1 year after. Although, sinasabi ng American Advisory Committee on Immunization Practices or the ACIP in their 2015 M&M or Mortality Morbidity Report that their recommendation is more than 65 years old, both for PCV13 and PPSV23. However, it is recommended for Filipinos at 50 years old because of lower life expectancy, so inadjusted to 50 years old. Adult Filipinos who were previously vaccinated with PPSV23 at less than 50 years old, but who are now 50 years old or more, may receive 1 dose of PCV13 at least 1 year after then another dose of PPSP23 after 1 year of PCV13 dose. Alright, so if the patient received previous PPSP23 at 50, and who are now 50 years old, okay, they may receive PCV13 and then give another dose of PPSP23 after 1 year of the PCV13 dose. Adult Filipinos more than 50 years of age who were previously given PPSP23 without PCV13 may opt to be given another dose of PPSP23 5 years after. So parang ang recommendation talaga is to give the PCV13 first, followed by PPSP23, no? But if the patient was given PPSP23 muna, alright, without PCV13, then you can give, I think sinasabi natin every 5 years na revaccination, although this is a weak recommendation with very low quality of evidence. This is based from the systematic review wherein the antibody response, no, was lacking, no, especially in booster doses of PPSP23. Although there are some GMT levels that can be reflected to vaccine efficacy, but the data was lacking if for multiple vaccinations is recommended or if it can actually sustain kanina vaccine efficacy over time in patients, in elderly patients that are immunocompetent. I think that is my last slide. Thank you very much.
Thank you to both our speakers. In the interest of time, we may not be able to entertain questions, but if you have questions or clarifications, you may ask our speakers anytime after this lecture. So I'll call both Dr. Antonio and Dr. Dessi back on stage for their certificates of appreciation. Please proceed to function room 3 for the closing ceremony.
Kaya yung